In the second part of my talk on the long QT syndrome, I will discuss primarily risk stratification and modifiers. As for risk stratification, in this paper of 2003, we were able to demonstrate that out of a large number of patients followed for almost 30 years, 13% had a cardiac arrest or died suddenly before the age of 40 and before initiation of any treatment related to the long QT syndrome. So 13% is a rough number that you can expect to die within the population of long QT syndrome when they're not treated. I have also to add that in those days, the patients identified as long QT syndrome, affected by the long QT syndrome, were usually more severe than what we see nowadays. I will come shortly to the issue of patients with a disease-causing mutation, but with an almost normal QT interval. The question is whether or not their risk is equally high. In this study that we carried out with many co-authors using the data from the International Registry for the Long QT Syndrome, the one that Art Moss and I established in 1979, provides useful information. Among this large number of subjects, you see that 15% of those with a prolongation in the QT interval either died or had a cardiac arrest. Those unaffected, the family members unaffected, at a minimal risk, 0.4%. By contrast, those carrying a disease mutation, but who had a normal QT interval, had a small but not insignificant risk. That is why, in my opinion, it is wise to treat them and protect them. The next two slides show you in rather large numbers what happens in terms of a probability of a cardiac event or of sudden death over time. This one deals with the probability of a syncopal event. And as you see, after age 25, females continue to be at risk. Males are at much lesser risk above age 25. And this becomes even more dramatic when we look at aborted cardiac arrest and sudden death. Females continue to die, males do not. Now, this has practically important implications because it raises the possibility that a male asymptomatic of therapy until age 25 is at very low risk, and therapy may or may not be performed. Now, of course, the length of the QT interval will provide important information and also the type of mutation. In the next slide, we will look at something else. We will look at a population where everyone was symptomatic. In other words, everyone developed either syncope or cardiac arrest or sudden death. And I wish you to look at the vertical red bar. You see that after age 25, among LQT1, whereas females continue to have events, this is not so for males. And indeed, in males LQT1 asymptomatic by age 25 or 30, if they have a normal or borderline QT, we often consider not to initiate treatment. The situation is not the same for LQT2. As you see here, both females and males have events after age 25, and the same goes for LQT3. So it's only for LQT1 that being asymptomatic for 25-30 years indicates a high probability of never developing symptoms. In 1979, I dared to propose something that was actually not very well received by my colleagues. What I did propose was that the spectrum of long QT syndrome might have been larger than previously thought and might have included patients with a normal QT interval. It took 20 years to prove it. And this was done when, in this study with my colleagues Silvia Priori and Carlo Napolitano, we were able to prove that penetrance in long QT syndrome can be low. Penetrance represents the percentage of mutation carriers showing the phenotype of the disease. And the low penetrance implies a relatively low sensitivity of the clinical diagnosis, which means that there may be a number of false negatives. In other words, individuals whom you think have not the disease while they actually do. And this is clearly evidenced in this slide when we have quantified the phenomenon. For LQT1 is very frequent. 1/3 of them, when I say of them, I mean patients with an LQT1 disease-causing mutation may have a normal QT interval. 19% for LQT2 and 10% for LQT3. So it's important to remember that when you are dealing with a family with members who clearly have the long QT syndrome, you have to be careful before excluding the disease in their siblings with a normal QT interval. That is why genetic testing is mandatory in all the family members. In the last part of this second talk, I will be dealing with modifier genes. They are important because each of us dealing with genetic disorders has to face from time to time the following very disturbing clinical question. Why is it that among two siblings with the same disease-causing mutation, one suffers cardiac arrest and the other goes through life without any cardiac event? It's a complex question. And the interpretation that most people give relates to the existence of what we call modifier genes, genetic variants that can modify the effect of a given mutation. During the last 20 years, the study of modifier genes has been a major part of my research. To identify modifier genes, I believe that it is wise and useful to study what we call founder populations. Founder populations derive from a few ancestors with subsequent isolation, geographic, cultural, or religious. Genetic studies can treat this population as a single family, allowing a comparison between mutation carriers with and without clinical events, and the observation of phenotypic differences influenced by environmental or genetic factors different from the primary mutation. So one has to identify founder populations, but you don't find them everywhere. There are a few countries where they can be found. In some region of Canada, in Scandinavia, and in South Africa. And I have chosen South Africa for my research on modifiers. This has been made possible because around year 1690, a Dutchman left the Netherlands and went to South Africa. This was because the Dutch in South Africa had the Company of the Indies. This man settled in Stellenbosch. He was affected by the long QT syndrome, type 1. During the following 300 years, his genes and his mutation, A341V, traveled extensively. With my partner, Professor Paul Brink, at the Stellenbosch University, we identified 25 families, all descending directly from the Dutchman with long QT syndrome. All the affected individuals carry the same identical A341V mutation on the KCNQ1 gene, so they have LQT1. This slide shows you a general picture of our founder population. We now have about 500 mutation and non-mutation carriers. This mutation is very severe, and 82% of the carriers have either syncope or cardiac arrest or sudden death. This IKS current, as you already know, is essential for QT shortening during heart rate increases, and the events in these families are primarily related to emotion or exercise. This slide shows you the distribution of the QT intervals among the known carriers in the family and the mutation carriers. The carriers obviously have a much longer QT interval, but that's not the issue. What I wanted to look at is how wide is the distribution of these QT intervals. These individuals, the mutation carriers, have the same identical mutation. They should have the same loss of the IKS current and a long but similar QT interval. By contrast, their QT interval is all over the places. This is immediately suggesting you that there must be something else that modifies the length of the QT interval. During the last 15 years, we have identified 4 modifiers. 3 of them in yellow are genetic modifiers that increase the risk. In contrast, in green, you see the one polymorphism that acts as a protective factor and reduces risk. Not having the time to enter in all details about modifier genes, I leave you with his recent review that deals specifically with modifier genes for sudden death and specifically for the long QT syndrome. These will provide you with adequate information. And finally, my recommendation for readings is listed here with these 3 papers that probably can help you to learn more.